be heard, and we are going live. In just a moment. Welcome everybody as you're joining the HCMA Big Hearted Warrior Tour. We will be getting going in just a few minutes. We apologize for the slight delay in our start time, but we had some things to get organized. So in the next few moments, I'm just going to give everybody a chance to file on in, make sure that we get our nice starter slide on Facebook, and we'll go through some housekeeping tips before we get started. Okay, great. We are now live on Facebook. So welcome to the Facebook viewers. And I wanted to tell you that we are going to be streaming via Facebook tonight, but the event is being recorded live from a webinar software through Zoom. The link is here on the Facebook page. If you would like to join us for the Q&A session at the end of the evening, please log in to the Zoom room. We will not be taking Q&A from the Facebook page. It is currently 7:10 p.m. Eastern Time on January 14th. If you're watching this presentation anytime after that, you can put your comments below and we will try to answer your questions as we see them pop up on Facebook. But if you're watching us live, come on over to the Zoom room and join us there. So I'm going to do a stop share here for a moment, and I'm going to bring my screen back into alignment. And I wanted to welcome everybody tonight to this event where participants are still coming in right now. The participants should know that they are they're in watch only mode. This is a webinar. At the conclusion of the meeting, we will be opening mics for Q&A when we get to the very, very end. If you have a question during the presentations, you can use the Q&A option at the bottom of your screen. Our faculty is welcome to answer your questions at any time. If they want to hold on to them and wait until the answer session, we can handle all of the Q&A at the end. So we might pepper it through as we go. So without further ado, I wanted to welcome our team at Aurora. And you guys have changed your name since we started. So in my brain, you're always going to be Aurora, but it's Advocate Aurora in Milwaukee, Wisconsin, with the world-renowned, very famous, one of those guys. I read the articles he wrote from before I was able to really even pronounce hypertrophic cardiomyopathy, Dr. Jamil Tajik. Jamil, you want to introduce your team to our viewers?
Thank you, Lisa. Hello, everyone. It's very pleased to welcome all of you to this webinar coming to you live from Aurora St. Luke's Medical Center in Milwaukee, Wisconsin. I'm joined by my colleagues and they are moving around, but let's see. I have Dr. Asad Ghafoor. There he is waving. He's the big guru of heart failure advanced therapies, and you'll be hearing from him towards the end of this program. Dr. Patricia Galaska in the bottom left. Is that how everybody's seeing you?
They should
Bottom left, she is on the screen. And Dr. Patricia Galaska is an imaging expert, particular interest in cardiac MRI, but also in CT, of course, in Echo. And she's a great asset we have in our Hypertrophic Cardiomyopathy Center. And the chair that's empty will be occupied by Dr. Where is he? Sohail Alakaban. He's the interventional expert and will discuss the latest technologies, techniques, and methodologies for relieving outflow tract obstruction that many of our patients with hypertrophic cardiomyopathy have, and we'll discuss that further. Dr. Sra, who's not currently on the screen, will be presenting soon after me. A slight change in the program, and I would introduce him when he shows up.
Fantastic.
Back to you, Lisa.
I'm going to take over for a little bit. I'm going to give everybody a little tour of what to expect tonight. So I'm going to do a little screen share. While I've got my screen share up, we're going to be putting a poll. And I'm going to launch that poll right now. And if you're participating on the Zoom room, if you would be so kind as to, while I'm talking, you can take the poll And at the end of my talk, I will go over the poll results to show everybody kind of who's here and what point of view you're coming from. Okay, so I'm going to do my screen share. And there we go. So let me move everything around, do a little housekeeping on my screen, and there we go. So again, welcome everybody, and thank you for joining us. We were supposed to do this event back in November, so some people who signed up, I hope they found us here at the new date. We did send notices out, and if not, well, you'll be watching it later. This is the 10th or 11th session that we've had in the Bighearted Warrior Tour. We have a whole year worth of programming coming up for you, so do check out some of the other events that will be coming up. I want to start by thanking our sponsors of this event, Myocardia, Boston Scientific, and Invitae. I'm putting Cytokinetics last because I wanted to give a big shout out and congratulations to Cytokinetics. It's kind of a big week for them. They have received FDA approval for orphan drug classification for the development of a drug for hypertrophic cardiomyopathy. And yesterday, they dosed their first patient in Redwood HCM. So it's kind of an exciting day for them. They're a sponsor of our event and obviously a partner in helping find better treatments for those with HCM. So congratulations. So tonight we went through a little bit of who's going to be talking, but let's talk about what we're going to be talking about. I'm going to talk to you a little bit about some of the programs that are available from the HCMA. Dr. Tajik is going to share a 50-year odyssey with HCM. I'm really excited to hear that talk. We're going to hear about MRIs and imaging. We're going to talk about catheter-based ablation, alcohol septoablation for the treatment of outflow tract. We're going to talk about a matter near and dear to my heart, pun intended, heart transplantation and advanced heart failure. She's back there in a box. I might bring her out later for a tour. If you don't know what I'm talking about, I should bring her out later for a tour. And atrial fibrillation in HCM, not necessarily in that order. We will be doing Q&A at the end. Okay, I'm starting this talk off incredibly differently because I wanted to take a moment to make sure everybody truly understood where the HCMA came from. Last Saturday would have been my sister's 62nd birthday. My sister was born with an atrial septal defect, had nothing to do with hypertrophic cardiomyopathy, but I did find something that I did want to show you. This is my mother's diary. In my mother's diary is the bill from my sister's open heart surgery. Here is the bill. The total amount for open heart surgery in 1964. I'm sorry, 1963. I have that date wrong. November 10th, 1963. $727.30. She was in the hospital for 2 weeks. So times have changed, haven't they? While they were in doing her atrial septal defect surgery, they told my mother there was something else wrong with her heart, but not to worry about it. It wasn't until the mid-70s when Lori was diagnosed with idiopathic hypertrophic subaortic stenosis, IHSS, the old terminology for HCM. Her life got a little chaotic there for a while. She was in and out of the NIH, pacemakers, in and out of the hospital afterwards. And unfortunately, at the age of 36, she suffered a cardiac arrest. And 5 days later, she died and became an organ donor. It was her death that led me to look for better answers so that other families didn't have to go through what our family went through. And a couple of months after her passing, her crazy little sister decided to start a 501c3 nonprofit organization that you now know to be the Hypertrophic Cardiomyopathy Association. So just wanted to take a moment and acknowledge my sister Lori, who I'm going to finish up my talk with a little bit of an update on her story 25 years later. So how did many of you get to diagnosis of HCM? Well, you got there probably because they told you something else was wrong first. Many patients who come to the HCMA had been told they had athletically induced asthma, panic attacks, anxiety attacks, depression, mitral valve prolapse, and innocent heart murmurs. And when that happens, we get frustrated and we're told that the answer is something that it really isn't. So why do I bring this slide up in the beginning of a talk? Because we know that you've been misled by misinformation over the years. And we want to make sure that you get some good data today to understand why these things may have happened and to understand how to deal with each aspect of HCM, which our fantastic faculty will be talking to you about tonight. So they're going to be talking to you about a number of different pathways in HCM. I don't know why my slide is getting stuck here. There we go. And that is, you might be asymptomatic at low risk of cardiac arrest and just be gene positive or only be gene positive. Those people are going to require follow-up over their lifetime. Some patients are going to be deemed to be at high risk for cardiac arrest. They'll need defibrillators and medication. Some will have obstruction with advanced heart failure, and they might need an alcohol septal ablation or surgery or meds or sometimes a combination of all of that. Those who have advanced heart failure with depressed ejection fractions may need to go on to advanced heart failure therapies, including transplant like me. And some people are dealing with atrial fibrillation and stroke risk, and they might need to speak to an electrophysiologist about options to get rid of that AFib. You're all a little bit different. And that's the critical thing about HCM, and that's why high volume care matters, because you are all a little bit different. So if you look at the data from the American College of Cardiology about what the average patient or average physician sees in their practice, they see about 10 patients with HCM. That's not a lot of patients. And that's kind of the validation and the reason why we believed in a high volume center of care model, which we're going to talk about now a little bit. So we call them HCMA recognized centers of excellence. And there's a whole process to become a center of excellence, which I'm not going to spend time talking about today. We're just going to talk about the programs that we have existing right now. As of January, or actually October of 2020, we have 41 fully functioning HCMA recognized centers of excellence. There are about 45,000 individuals in the United States being treated at one of these programs, and these numbers are growing by the day. We slowed down last year because it wasn't exactly easy to go out and do site visits during COVID. So now we're trying to figure out how to do the virtual site visits because we have 9 applications in-house for new centers that want to develop, including Hawaii and Colorado and Alabama and a few other programs. So we're excited that there's still great interest, and we hope to provide better care for patients all over the country very soon, and maybe even some international work. Okay, so what is a center of excellence and how is the patient flow handled? HCM is serious business. I get to have a little fun with some fun slides once in a while. So here you guys are up here as you patients with hypertrophic cardiomyopathy. Kind of the same, but all a little different. So when you go to a center of excellence, you're going to go through a funnel of testing. They're going to look at imaging, electrophysiology, evaluate you for heart failure, look at your genetics, and hopefully ask questions about how you're doing, how your mental health is holding up with this new diagnosis or existing diagnosis. So you go out to these buckets. Maybe you go to surgery, maybe you go to interventional cardiology, maybe you're having a baby and you go to maternal fetal medicine. That's great. They all provide a great service to the HCM community, but you really need to come on back up to your HOCMologist, or in this case, Dr. Tachik, who will make sure that your care is being met completely and that your AFib isn't being treated only as AFib, but HCM AFib. So we're looking at the muscle function as well as the electrical issues. And we're going to take care of the whole person. This model proves to be very successful for patients with HCM. And so much so, and I'm kind of happy to say this, when the guidelines document was being written, they took the HCMA Center of Excellence model to heart. And instead of calling it HCMA Center of Excellence, they called them comprehensive HCM programs, primary, and then primary cardiology. The difference being some of the HCMA recognized centers of excellence are really what they call primary here. They may not have strong surgical programs, so they may refer out to higher volume surgery. They may not have heart transplant. They may refer out to transplant. They may not have maternal fetal medicine, and they'll refer out there, but stay in concert with your care. A true comprehensive program can handle everything from soup to nuts, from screening your family members to transplanting your heart and the maintenance of that thereafter. So there's different structures of programs. You don't always have to go to the highest volume program for your HCM, but it is advised that you do check in with an HCM Center of Excellence to ensure that you're not missing anything. What do we know from the patient's perspective? We do surveys. We ask people feedback all the time. We know that patients who are treated in HCMA recognized centers of excellence have better quality of life, both physically and mentally. They feel understood, sometimes for the first time in their whole lives. We know that the outcomes from invasive procedures have lower complication rate, and they receive way better care than they would at the community for these complex procedures. And we also know that patients have an opportunity to participate in clinical trials, which you don't have at a community-based hospital. So that was just a little bit about Centers of Excellence and why we believe in them so much. I could probably give a 3-hour talk on that, but I'm not going to tonight. I do want to let you know where to find support for HCM if you are a patient or a family member. We have a Facebook page. Everybody has a Facebook page these days, right? But we have groups, and those groups are private groups where you can go and have private discussions with trained moderators who can help guide you through questions and answers, as well as deal with input from the community. We love, questions. Has anybody ever dealt with, fill in the blank, pregnancy in HCM? Has anybody ever dealt with having their ICD replaced? And your patient peers can assist you in understanding what to expect. So we have 2 groups right now. One is a parents group and one is a general community. And we are about to launch our first international group. So the term HCMAI is something that you're going to hear in the future. And we're actually going to be launching Sweden first. Don't ask why Sweden. It was randomly chosen, but I'm going to be starting with Sweden. So stay tuned for that. That might be up as early as next week. Other things that we have for support is our online support community. And I know that the group here in Milwaukee has a great support group, but it's kind of hard to meet when you're not allowed to be in touch with each other. So the HCMA has formed online support groups, and you can sign up for one at any time. We will be having over 20 opportunities of support groups every month online with, again, a great group of volunteers that we've trained, and that they're learning how to do this too. So it's a little bit of a learning process. And we'll be bringing in specialists to speak to you during these support group meetings. Not quite as in-depth as a Bighearted tour, but we might have somebody come in to talk about AFib or to talk about genetic testing or to talk about the 50-year history of HCM. Hint, hint, nudge, nudge, we'll be asking our partners in Milwaukee to join us on some of those meetings. You can register online and then join us in a Zoom room. There are maximum 25 individuals per room. Probably by the end of the second quarter, maybe beginning of third quarter, we're going to start our peer-to-peer Bighearted Friends Network for people who aren't support group people, but do want some support. We'll think of us as the eHarmony of HCM. You'll fill out a questionnaire, somebody else will fill out a questionnaire, and we're going to try to do some matching so that we find people who have like minds and want to communicate together. The peer-to-peer may last one conversation, a month, a year, 3-year procedure, or you might become lifelong friends. We're not putting timestamps on these. We're just giving you the opportunity to meet somebody else one-on-one. Okay. We're doing the Share Your Story program. We're doing a lot more podcasting. I have 2 standing podcasts, one with Harry Lever every month and one with Marty Marin every month, but I'll be reaching out and bringing in other Center of Excellence directors and interesting people of note in the community to do different podcasts with me once or twice a month as well. So Dr. Chajic, get ready for your invitation. It's coming soon. We're also doing the Patient Share Your Story, and we're going to be doing one next week. We're going to bring in one of Dr. Lever's patients, and we're going to kind of talk through her process and how she landed where she is and how she's doing today. So these programs develop over time, and if you want to share your story with the HCMA, you can sign up to become a volunteer. But I'm going to have y'all put a pin in that for about 6 weeks because we're about to launch a brand new website. And when the new website comes up, there'll be more interactive forms that you can fill out and tell us what you want to do to get involved. We have started, actually, we're in our 2nd year of the Elizabeth T. McNamee Legislative Subcommittee, and we're going to be working on some endeavors, probably starting at the state level, although with changes that have happened in the past couple of weeks, there might be an opportunity for some additional healthcare reform at the federal level. And what we're looking to start with here is completely bipartisan. Everybody can agree that hearts are important and children's hearts are even more important. We're trying to include the same questions that are asked in a pre-participation screening physical in every well child examination in the United States. And if we can do that, we can identify not only children who are at risk, but families who are at risk for HCM and other forms of heart disease. So we hope that you'll all join us in those endeavors and get your state houses involved, and let's do some good for the people by passing legislation that finally looks at children's hearts in a proactive way as opposed to waiting for disaster to strike. Let's see, where are we? Oh, here we go. For those who did not participate in our patient-focused drug development meeting, you can view it online at our YouTube site. Not going to spend an awful lot of time talking about that tonight because what's more important than the PFDD being held and you can watch it, you now can see the report. I have a little thing for my sister's birthday. I try to do something of significance to the community as a birthday gift. So this year on January 9th, we submitted our Voice of the Patient report. What this is an opportunity for drug makers and regulators to understand what it is to be an HCM patient, so that when they're designing clinical trials and evaluating new drugs and therapeutics, that they understand what we're looking for in terms of treatment. They understand where our burden is. And because they understand, they can develop endpoints for clinical trials that make a difference to us. Rather than writing to a biomarker, we don't care if our BNP came down 10%. We want to be able to walk across the street without losing our breath. So if they can identify those markers that we can use to prove success, that's better for us all. And this report is one of the tools to help them do that. You can download it right now from the link. Well, I'll put the link in the chat box for later if you want to go see it. It's right on the HCMA website. Just go into the search engine and hit for Voice of the Patient. I want to thank everybody for their time tonight. We've got a lot to get through in a short period of time. All of our Center of Excellence partners have been so wonderful to work with us on these programs, our staff, our board. I did not introduce two of my staff members who are here tonight, Amy Mann, our meeting coordinator, and Julie Russo, our volunteer coordinator / intake coordinator. They're with us here tonight. I want to thank all the volunteers of the HCMA. And for those who don't know who Brandy is my heart donor. That's pretty much all I know about her. But without her, I would not be here tonight. And the update that I promised for you. Remember I said Lori's story is not over yet? On her birthday, I was privileged to announce the gender reveal. My nephew, John, Lori's son, and his wife, Kimberly, are expecting their first child in July. And it's a boy. So Lori may not be with us anymore, but my sister would be a grandma and she'd be really happy about that. So I'm going to hand it back to Dr. Tajik, and I cannot wait to hear his talk.
Thank you. That was a very nice introduction you did to HICMA and what you have done. Remarkable organization, Lisa, and congratulations.
Thank you.
Okay, now comes my challenge. Share the screen.
I have faith in you. And if we could just remind the faculty who is not speaking to mute their mics. Thank you.
Okay, so in the next 15-20 minutes, ladies and gentlemen, I'm going to share with you a personal 50-year odyssey with the disease now known as hypertrophic cardiomyopathy. In 1970, when I started my career in cardiology, as a young person, I was intrigued, fascinated, and challenged by a disease entity called IHSS, at that time considered to be quite uncommon, and it was only recognized if it had the obstructive variant of the disease. And many of you who are listening know when we talk about obstruction to the left ventricular outflow tract, creating a murmur. And that's how some of you come to the attention of your caregivers, and finally to our center or centers of excellence, as Lisa just mentioned. So in the next, as I said, the time allotted, I will share some of the major milestones that have occurred along the way, this 50-year journey of hypertrophic cardiomyopathy. What have we learned? The first thing we have learned is this, that the condition hypertrophic cardiomyopathy is very heterogeneous disease. It's not one condition and nothing fits everyone. And we have to individualize and personalize investigation and management strategies for each individual patient with hypertrophic cardiomyopathy. Heterogeneous group of individuals and challenges that are posed by each individual. Now, let's start with this heart. Lisa shows her heart around. This is a patient who was a young patient and had died suddenly. And in this heart, I'm just showing the fact is, this is a longitudinal cut of the heart of this individual. For orientation of those who don't see these specimens, the head is on this side, where Dr. Gafoor is, and the feet are on this end. Now, what we are looking at, the cut surface, this is the ventricular septum that majority of you very well know. This is what becomes hypertrophy, thickened in this condition by far the most. And we note also here that there's the mitral valve, an aortic valve, and this is the left ventricular cavity. At the bottom, we see two microscopic sections. On the left is normal heart muscle with very nice parallel orientation of muscle fibers. This is normal heart. In contrast, you can see very clearly that the patient with the hypertrophic cardiomyopathy has very disorganized myofiber architecture. Some of the fibers may be running perpendicular to the other fibers, and interspersed between the fibers is this material which is referred to as the fibrous tissue or scar tissue interspersed here. So the condition is characterized by marked disarray of myofibers and fibrosis or scar tissue formation in there. So now let's transform this heart into a beating heart. This is what echocardiography does. You can see fairly identical morphology or structure that is seen, very thick septum in this individual that you can see here. And in motion, you'll see that the cavity of the pumping chamber is small, and there is obliteration at this level, producing obstruction as part of the mitral apparatus abutting against the ventricular septum. And this is what we'll discuss a little further. So echocardiography. So in management of this assessment of these patients, we first have to establish a comprehensive diagnosis, hopefully non-invasively. In my early career in the 70s, diagnosis used to require cardiac catheterization in order to detect the condition, detect the obstruction, and so forth. Echocardiography now plays the seminal role, because the cornerstone of assessment of patients with hypertrophic cardiomyopathy, and it provides a very comprehensive evaluation. I'm not going to go through the whole list here, but just to suffice it to say, many of you have had at least one, if not many, echocardiograms performed for regular assessment of hypertrophic cardiomyopathy, and that's where this role of this particular modality is. So there is 2D echo, 3D echo, there's Doppler methodology, and so forth. Now, with the comprehensive echocardiography, as I mentioned, the condition is very heterogeneous, and that is characterized by the fact that the thickness of the septum or the left ventricular wall involvement is also very heterogeneous. Just in this schematic, the thickest portion is just below the aortic valve here. Here's the mitral valve, and here's the knuckle bulging into the flow of blood, producing obstruction. In this heart, the whole of the ventricular septum, the partition between the two pumping chambers, is uniformly thickened, hypertrophied. In this heart, the septum is not hypertrophied. The free wall of the left ventricle is where the major hypertrophy is localized. All walls are concentrically or symmetrically hypertrophied. And lastly, this variant of hypertrophic cardiomyopathy, where the apex of the heart or tip of the pumping chamber is the one markedly hypertrophic. So there's a spectrum of morphologic abnormalities in this particular condition, and so are the functional abnormalities. I'm just going to show a couple of echoes. You undergo these and you see some of this example. Here, just keep looking at this one. We can see the septum here is only 16 millimeter in this individual. The mitral valve, aortic valve, there's no obstruction to the blood flow in this heart. In contrast, you will see this example where there is big, thick septum bulging into the outflow tract, and the mitral valve is coming across, narrowing this area at rest. And then with provocation, and some of you may remember receiving an inhalation of to sniff a drug called amyl nitrite, and that mimics exercise right in the echo lab. And you can see now the mitral valve abuts fully across the ventricular septum, producing big time obstruction. As I mentioned earlier on, previously heart catheterization was the only way to detect how much is the obstruction. Now this we can do routinely in different states and measure the level of obstruction in this individual at rest, about 30, mid-30s, and with provocation, mimicking exercise, it reaches 100 millimeters mercury, which is very severe degree of obstruction. This example shows massively hypertrophic ventricular septum. Here is this septum, this huge in this young individual. This is the thick septum, and there is the mitral valve abutting against the septum, producing the obstruction to the flow of blood. Now, every 5 years, there have been developments. So I showed you the Doppler measuring the gradients. Now, 5 years later, in the mid-late 80s, came the color flow imaging advances, where we can see the flow of blood with each heartbeat. And here we can see also this being the left atrium, regurgitation of mitral valve leaking in this individual with severe obstruction. So you can see very clearly a very comprehensive assessment of the structure, function, hemodynamics is done by echocardiography. So this was a major milestone, great achievement, and now we come to the treatment, management of such individuals with hypertrophic cardiomyopathy. Now here, there has not been any major advances. Beta blockers, almost all of you are probably taking this, calcium channel blocker, most of you as well, and those in whom the obstruction is not responding to these two drugs, we add a third agent, which is the diisopyramide or Norpace. And that's the sequence followed in most of the individuals that have obstructive disease and are symptomatic. However, if they are intolerant to these medications, or we are not getting the desired effect from these medications, then we have other invasive methodologies to offer. Myectomy is the surgical operation to shave the muscle, and Alko septal ablation. And I'll just say a couple of words, and Dr. Sohail Rakaban will discuss ablation in more detail. So what was the next big milestone? Every 5 years, I say something major has happened in this field. And now we are 1990, tremendous excitement took place because the first gene producing the disease hypertrophic cardiomyopathy was discovered. And since then, in the last 30 years, up close to 22 sarcomeric and some non-sarcomeric genes have been detected with large number of mutations. And this is the most exciting area of finding what is causing the disease in our patients and how it transmits in the family. So genotyping is routinely performed in our center for individuals suspected of having hypertrophic cardiomyopathy. Now, two management that are non-medical are surgical resection of the septum. The bulge, as you see here, the surgeon opens the aorta, protects the aortic valve, and carefully then resects this amount of muscle from the septum to open this channel. And surgery has been around for 55, 60 years. Well established, it is the almost referred to as the gold standard for management of obstruction, particularly in the younger people. And it's the go-to procedure for those individuals. The new kids that came in mid-95s, remember 1990 was the genotype. 5 years later, comes the Alko septal ablation, introduced in London, England. And it was in 1995 that this particular, what looked like pretty radical procedure to inject alcohol and to make a portion of the heart muscle purposely die in order for it to shrink and open the channel. And Dr. Alakaban will say more about this particular procedure with you. That was 1995. Then there is quiet aspect. Until recently, we find the hypertrophic cardiomyopathy in women behaves completely differently than in men. Just like we all know, men are from Mars and women are from Venus. And bottom line is the survival of women with hypertrophic cardiomyopathy shown in this graph in red is inferior to of the males with the same condition. And what are some of the reasons? Women present at advanced age, they present with more symptoms, they have worst exercise performance and tolerance is reduced, exercise tolerance. Their hemodynamics are more obstructive and their management shows worse survival under our care. So more attention needs to be paid to these individuals in detail, and earlier management is required. So I'm shared with you some major milestones in this journey of the last 50 years, and have been very exciting insights that we have obtained. Now, before I stop this, another major excitement has occurred in last year. As you can see, new drug, mavacamten, a whole new way of management. Two very important trials were published in just last year. Original one was in 2019, and a very important part is still ongoing. So that is another exciting area, and we'll hear much more about this in clinical practice now. So this odyssey will continue beyond 2020. I'm excited to continue this odyssey with all of you. And from here on, Lisa, you want to see this?
Wow.
This is this morning.
Really?
Lake Michigan.
That's beautiful.
Absolutely gorgeous.
Yeah, I haven't seen that in a really long time because I can't leave New Jersey.
Okay. So, sorry, I am done here, and we can move on to, is Dr. No.
I don't see him yet. He's not quite
Okay,
here. So
then
we'll give him another minute to join us and see if he pops in. Otherwise, we'll have one of the other colleagues jump in. But let me show the results of the poll so we know exactly who's here with us. It's predominantly the Midwest. We have some Southeast US residents joining us tonight. 78% are patients that took the time to take the poll. 2% are also family members of somebody with HCM. We have a number of people dealing with lots of different issues here. So we have a newly diagnosed, 89% are on medication, 67% have an ICD, 44% have had an alcohol ablation or a myectomy, 89% have AFib, 22% of us have lost a family member to HCM. And I'm with my brethren this evening, it appears, because 22% have had heart transplant, so a transplant. Everybody who took the poll has had genetic testing, and we don't have anybody tonight that's taken the poll that is weighing an option for therapy, but I know that people who will watch us afterward will probably be in that classification. So I bought another minute and a half of time for your colleague, but unfortunately he didn't make it here. He's probably still stuck in his meeting. So do we want to go on to Patricia, or did you want to go in another order?
I think Patricia is next in the imaging. Continue that particular discussion.
Sounds perfect. Thank you. And let me just share my screen here.
Thank you. And then we'll all go put ourselves back to sleep in the back, and we'll put our cameras off and listen intently.
All right, perfect. Are you able to see my screen or?
We do have your screen. Thank you.
Perfect, great. Thank you so much, Lisa, for this invitation. Dr. Tajik, thank you for this beautiful overview of hypertrophic cardiomyopathy and this 50-year odyssey. I will be talking over the next 10 minutes about the contributions of cardiac MRI and specifically how it helps us with management of hypertrophic cardiomyopathy. I wanted to point out here with the initial picture here on the right, we have Mona Lisa, which a lot of us have seen. And on the left here, we have a picture of a hypertrophic cardiomyopathy heart. And we can see here that the dark portion is normal heart. And we can see here that the white spots here, that's actually scarring within the heart that can occur in hypertrophic cardiomyopathy patients, as we know. So question is, this is what mainly cardiac MRI helps us with, amongst other things, but cardiac MRI, what I want to point out, it's not just pretty pictures, it adds a lot to hypertrophic cardiomyopathy management. So over the last several decades, we have learned that hypertrophic cardiomyopathy diagnosis is mainly imaging based, so non-invasive based. It started with angiography, as Dr. Tajik have talked about, has gone through Echo, and eventually we have discovered MRI, which helps us identify these areas of increased wall thickness. Because as Dr. Tajik beautifully has said, hypertrophic cardiomyopathy has very diverse phenotypic expression. So meaning that it can be localized in any portion of the heart, as we can see here on our first picture. For example, a patient might have increased wall thickness in the septum. On the second picture here, the increased wall thickness is more towards the apical portion of the heart, as well as within the mid portion where the stars are. And here is another patient with very peculiar, much different increase in sort of the apical posterior portion of the heart, as well as in the basal septum. So we can see here that hypertrophic cardiomyopathy can present in any form and any manner. As Dr. Tajik beautifully has described, this sort of odyssey has gone on for many, many decades, and it started with identifying the pathology, going through the angiography, and then discovering the echo, as Dr. Tajik is the father of our echo here, and then moving on to MRI, which gives us much higher resolution images, can enhance our diagnoses, can identify scarring, which is one of the most important things, and ultimately stratify patients for appropriateness for ICD or for sudden cardiac death.
Patricia, you're in presenter mode. So if you switch, the slides will be bigger.
Why should I stop sharing right now? Sorry, one second.
So
You just have to.
I was debating whether to stop on it. You're gonna have to stop your slides, switch the, you have two computer screens, I would guess, correct?
Oh, yes, I do, yes.
Yeah, put it back
One
up, switch the frame, and then you should be okay. Thank you for bringing that up. I was like, do I interrupt her?
Thank you. How,
Now just go into present mode.
how's that? Better?
Beautiful.
Better.
Okay.
Thank
Great,
you.
wonderful. Sorry, thank you for pointing that out. Wonderful. Okay, so again, hypertrophic cardiomyopathy is mainly diagnoses based on imaging. We can see here on the right, there's our echocardiogram, which is our basically, as Dr. Tajik said, cornerstone of our imaging and diagnoses. We can see here, this is a heart of a hypertrophic cardiomyopathy patient with a thickened septum. There are advantages to echocardiogram. It is a portable machine. It is ultrasound based, and it's widely available. And then we have, of course, our MRI here, and this is our MRI machine, which many of you might have gone through, which has its certain advantages, but it also has its limitations, which I'll go through later, such as for patients who are claustrophobic, they may need additional medications for them, or patients who have additional metallic objects, it might be difficult for them to have cardiac MRI, although it does not preclude them from getting cardiac MRI. But cardiac MRI, as we can see here, this is again an playing image of a hypertrophic cardiomyopathy heart. We can see here, again, gives us this very nice blood pool delineation from the myocardium or the thickened heart muscles, as we can see here. And that diagnosis of hypertrophic cardiomyopathy is essentially defined as over 15 millimeters anywhere within the left ventricle or the pumping chamber of the heart in the absence of any other reason for that increased hypertrophy in adults. So as we move on, cardiac MRI, what I want to point out here is does not only give us the morphology, just like the echo, where we can see the hypertrophied or the increased wall thickness of the heart, but it can also serve as a non-invasive biopsy of the heart. It can look inside of on the microscopic level at the tissue of the heart. It can describe sort of the fibroses or the scarring within the heart. As we can see here pointing out with the arrows, we can see here that the dark myocardium or the portion of the heart of the hypertrophic cardiomyopathy patients is normal here. And then we can see here that the bright areas or the light the white areas are scar, portions of the scar. And that scar usually occurs within the thickest portion of the heart. So basically what cardiac MRI does, it characterizes the tissue within the heart, which can give us a lot of sort of prognostic indicators or prognoses for these patients. And it can also talk about more of a microscopic fibrosis or scarring when we do our mapping techniques when we discuss interstitial fibroses. So cardiac MRI is a very useful imaging modality when it comes to diagnosing as well as defining the prognosis of a hypertrophic cardiomyopathy patient. It also can discover other abnormalities within the heart. We know that frequently patients with hypertrophic cardiomyopathy may have crypts, myocardial crypts, or elongated mitral valve leaflet. Also can have apically displaced papillary muscles. These are all morphological abnormalities which can be found commonly, and cardiac MRI can be helpful with further discovering them. So as I spoke before, it helps with diagnoses because of this high spatial resolution by identifying these areas of increased wall thickness. It also, the very benefit of cardiac MRI, that it can also differentiate LVH or left ventricular hypertrophy, increased wall thickness from other causes such as infiltrative cardiomyopathies, which can be, which require different treatment. It aids in sudden cardiac risk stratification with the amount of scar that we can see on cardiac MRI. Can also more readily evaluate patients with apical aneurysm, and again evaluate this extensive fibroses. Again, the disadvantages of cardiac MRI are the claustrophobia for patients, which may be claustrophobic. It may be difficult to go through cardiac MRI, but there's medications, there's assistance of anesthesia if needed, so we can always help with that. Cardiac MRI does require at least about 30 minutes of the time of being within the machine. It requires breath holding capability and following commands that are given during the cardiac MRI. Arrhythmias, patients with arrhythmias may impair the quality of cardiac MRI, but that's not a definite contraindications. And obviously metal devices, anything else such as ICDs, pacemakers, again, not a definite contraindications. And most of them, at least at this time, are MRI compatible, so patients go through with them. But some of the other metal objects or devices may preclude patients going through with cardiac MRI. So it's always important to inquire about it with your doctor, electrophysiologist, or your cardiologist, and follow through with it. So when cardiac MRI should be done for hypertrophic cardiomyopathy patients, and we have these wonderful guidelines right now, which were recently published in 2020. And one of the first things is when echo is inconclusive. So for example, some patients may not have good acoustic windows where we might not be able to define the increased wall thickness very well. At that time, cardiac MRI can help us sort of clarify the diagnoses. Cardiac MRI can also be helpful when distinguishing alternate diagnoses from increased wall thickness. So I'll show you a few examples just in a few slides that different patients may have different diagnoses when they have increased wall thickness. It may not be just hypertrophic cardiomyopathy. And then the very most important, one of the most important things is when decision to proceed with ICD is uncertain, or when we want to further risk stratify a patient or you in regards to when you're not a high risk based on current sort of recommendations, and we want to see if there's scarring within the heart. And this is actually one of my clinic patients that I have seen, a 37-year-old woman with family history of migraines, who has history of obesity. Her BMI is fairly high, 54, and a family history of HCM. And she essentially wanted to know whether her father had hypertrophic cardiomyopathy, and whether she had hypertrophic cardiomyopathy as well. As we can see here, this is her echo image playing, which she does have a pretty poor acoustic windows, or the wall thickness is not measured out very well. And we can see here that her basal septum was reported as just mildly increased, but when you can see here, MRI shows the thickness of the heart much better. And we can see here that she does have a substantially thickened heart muscle, which is diagnostic of hypertrophic cardiomyopathy. And we can see here that thankfully she only had small amount of fibroses or scarring within the thickest portion of the heart. And overall, her prognosis based on this was good. There's also alternate diagnoses which come into play when we look at thickened heart muscle. For example, patients may have thickened heart muscle because of elevated blood pressure, so hypertensive heart disease, because of other infiltrative diseases which can thicken the heart muscle, such as amyloidosis or storage disease or hemochromatosis. So it's very important to differentiate that, and cardiac MRI can be very helpful in differentiating that. And just to show you 3 examples here, this is a 60-year-old woman with a history of hypertension, atrial fibrillation, bilateral carpal tunnel syndrome, very thick muscle right here, very pathognomonic cherry on top sort of strain pattern from echo that we see in cardiology. Another patient also with very thick heart muscle, a 50-year-old man with hypertension and chronic kidney disease. And then another patient with 45-year-old man who basically had a discovered thickened heart muscle. We can see here septum on a pre-op echo. And we can see here that 3 different patients and 3 very different diagnoses. Patient 8 has diagnosis of amyloidosis. Patient B has storage disease, Anderson-Fabry's disease, and patient C has hypertrophic cardiomyopathy patient. So cardiac MRI can help us in diagnosing and sort of determining the further appropriate treatment for each patient. And we can see here again, cardiac MRI aids us in sudden cardiac death stratification by identifying left ventricular apical aneurysm, just as echo does, but also identifying this extensive late gadolinium enhancement that can help us further determine the prognosis of the patient and whether a patient should be getting ICD, because extensive LGE or fibrosis or scarring is associated with increased arrhythmias or sudden cardiac death, as I'll show you just in one more slide, amongst these other sort of established risks already according to the guidelines. And we can see here, this is, for example, when we are sort of considering an ICD for a patient, we look at all of these established risk factors and apical aneurysm here, which we can see here with red arrows on cardiac MRI. We can see the fibroses and the LV apical aneurysms, which some of you may have or may be diagnosed in the future. And then another thing is, if still none of these come into play, then if there's an extensive delayed gadolinium enhancement or fibrosis or scarring on cardiac MRI, we can see here, as seen here on this lower patient, the 35-year-old woman with exertional dyspnea who had very extensive scarring within the thickest portion of the myocardium. This can help us further risk stratify for ICD. This scarring obviously comes from the pathology of hypertrophic cardiomyopathy, from these increased collagen deposition, from this myocardial disarray, which Dr. Tajik has already shown. And we can see here this bright area here, this is all scar within the apex of the heart. And this can be an arrhythmogenic myocardial substrate, so substrate for arrhythmias and sudden cardiac death. And again, this has been correlated before in many papers very well. We can see here that there's the scar, and on histological section, we can see here that this is the blue is all scar within the patient of a hypertrophic cardiomyopathy. And again, the scarring or LG, delayed gadolinium enhancement, which we see with cardiac MRI, has been associated with many, amongst many has been published amongst many papers by many authors, and has been associated with arrhythmias and sudden cardiac death. And we can see here that if patients who specifically have more than 15% of fibroses or extensive fibroses are basically termed to be at a higher risk for arrhythmias and sudden cardiac death. So 3 points again: when should cardiac MRI be considered? When echo is unconclusive, when we want to define the wall thickness a little bit better, look for apical aneurysms, when we want to evaluate for alternate diagnoses, and when we want to assess for extent of fibroses and stratify for sudden cardiac death. Thank you so much, and I will welcome any questions or anything that I could answer.
Thank you so much for that excellent presentation. I wasn't quite sure where we wanted to go next. We're going to hold on to some questions for a little bit here. So let's get you to stop screen share. And we've got that. I'm going to go into the Q&A screen for a little bit. Patient is writing kind of a generalized question here. I've entered a new phase. I've started to have some shortness of breath and dizzy spell off and on with some rapid heartbeats. I had a cardiac MRI and a left heart cath, and the center of excellence. So far, it shows a stiffening of the heart muscle. What can I do to help my doctor figure out what's causing the symptoms? I've had surgery in the past. So I think we'll kind of wait till we hear from a couple of more of our speakers to address Jimmy's question, because I think maybe some of the additional topics might bring some light to that, but we'll get back to you with more specifics, Jimmy. But please do remember, we're going to be speaking in generalities here. To understand your own personal anatomy would require a consult with one of our HCM specialists, and we can't be diagnosing via webinar. So we will generalize the answers to that question. Dr. Tajik, you want to bring yourself off of mute for a minute and let us know where we're going to go next with the agenda, because I know we're missing a faculty member right now. So I just wanted to make sure we're going in the right order. You're still on mute, Dr. Tajik. The little button on the side.
We've been kind of waiting. Dr. Shah is the chief of cardiology at our center. He's got a lot of administrative duties. He was going to break away as fast as he could to join us. He really, really wants to be involved in this particular meeting and share his experience with ICDs and ablations. He's the master electrician of the heart. So let's see if we can show up soon. If not, then we go next to Dr. Sohail Alakaband.
Okay, so we are going to be discussing septal ablation and percutaneous therapies. And you can do a slide share whenever you're ready. So always that fun part of finding that button.
All right, can you guys see my screen?
Yes, we can. Thank you.
All right, good evening, everybody. Thank you to HCMA and Dr. Tajik for having us here tonight. So far, I have learned a lot. We have learned over the years from Dr. Tajik. He's the guru of HCM and continue to learn something new every time he gives a talk. And a great talk on MRI, Patricia. So my job is kind of simple in all this. I come in when Dr. Tajik gives me a call and says, we need you to do this. And that's where I fit in. We are just technicians. And our role is to help relieve some of this LV outflow obstruction. I know you heard Dr. Tajik talk about it. You heard Dr. Glashka talk about it. And that is not present in every hypertrophic cardiomyopathy patient, but in patients where it is present, it can be cause of major symptoms in the patients. And what we mean by LV outflow is this is a normal heart on the right-hand panel here. The ventricle where the blood collects, the ventricle pumps the blood out. It has to flow through this what we call left ventricular outflow through the aortic valve into the aorta and rest of the body. And this is the ventricular septum. And when the septum is thickened, as you heard, this is the area where in majority of the patients, there is asymmetrical hypertrophy compared to the rest of the walls. It creates this asymmetric bulge in the outflow, creating obstruction. So when the ventricle squeezes, and there is very little room for the blood to flow out into the aorta. And with what this also causes, it kind of pulls this mitral valve, the anterior leaflet of the mitral valve towards the outflow, creating a gap in the mitral valve. Not only creates obstruction for the blood to flow out into the aorta, it also gives a pathway for the blood to flow in the reverse direction up into the atrium towards the lungs, causing mitral regurgitation. And that can cause a lot of symptoms of shortness of breath. So this has been described very elegantly by Dr. Tajik's group, by Dr. Marin's group, that this outflow tract obstruction is something bad in patients with hypertrophic cardiomyopathy. It affects survival, and you can see patients who don't have obstruction live longer than those patients who have obstruction. And it also causes symptoms in these patients, resulting in heart failure. So as you already heard, the mainstay of treatment to relieve this obstruction is to help the heart relax and not to contract very vigorously. And as Dr. Tajik mentioned, we use beta blockers, which is the mainstay of treatment so far, until this new medicine that just showed up last year. But so far, beta blockers are your main medical treatment. And then if patients remain symptomatic, we can add calcium channel blockers or diisopyramide. So basically, we only have 2 or 3 medications that can be used to help relax the heart and relieve this obstruction. And in many patients, this works very well, and you don't have to do anything else. But in patients who are intolerant of medication, their heart rate is low, blood pressure is low, side effects from the medications, or who continue to have symptoms despite being on 1, 2, or 3 medications, then we move on to some kind of intervention, which is either removing that bulge in the heart muscle surgically, which would be myectomy, or the catheter-based interventions that I'm here to talk about. So surgery has been around for this condition for a long time. And what the surgeons do basically open up the aorta, look down the aortic valve, and take a scalpel and very precisely take out that bulge in the muscle and relieve that obstruction. It has been done repeatedly and with fantastic results at the Mayo Clinic. This is their data from a few years ago, 800 patients with very low mortality during the surgery, and excellent results with reduction of gradient. Gradient is the pressure that is in that outflow tract when the heart is squeezing. It should be, there should not be any gradient, and it goes down with surgery significantly. And patients post-operatively are doing much better, either with minimal symptoms or no symptoms after the surgery. And surgery, after patients have surgery, you can see the results from the Mayo Clinic group show fantastic results that after myectomy, basically you take that patient with obstruction and make them like a patient who did not have obstruction, and their lifespan is similar to patients without obstruction, as opposed to patients who are not operated upon and nothing else is done for their obstruction. You can see their survival over the next 10 years is much worse. So having said that, on the slide, it looks very, very simple. The surgeon takes a scalpel and shaves off this muscle. In reality, it's a very technically dependent surgery. The surgeons have to be very well trained. They have had to have done enough, and they need to do this surgery very precisely to take enough muscle out not too much and not too little. And in reality, what happens is the surgeons who don't have much experience either don't take enough muscle out, and after surgery, patients still are left with obstruction, or if you take out too much muscle, then you can cause other problems like a hole in the heart or heart block and need for pacemakers and as such. So when we look at general experience in the country, not just the Mayo Clinic and other centers of experience, the mortality from the surgery is higher, the complications are higher, the gradient is not reduced as much. So the results are not as widely applicable as the Mayo data would suggest. So if you get surgery at some other hospital, not Mayo Clinic, don't expect similar results unless the surgeons there are also trained. Plus it is a surgery. They have to crack open the chest, you have to cut the breastbone to get to the heart. So it is open heart surgery. So that has led to creation of some non-surgical catheter-based options. And as Dr. Tajik mentioned, this first in this group is this alcohol septal ablation. So basically the idea is to find the artery that supplies that muscle that is thickened and bulged, put a wire and a balloon down that artery, and then inject some alcohol, which over time causes a controlled heart attack and makes that part of the muscle die and thin out and scar and not squeeze hard, and creates what the surgeon would create by surgery by thinning out that part of the muscle. So as Dr. Tajik mentioned, this was the brainchild of Dr. Sigwart from United Kingdom in 1995. He published his initial result on his first 3 patients of this alcohol septal ablation. The beauty of the procedure is that it is very easily teachable. People can, we do this kind of procedure all the time with balloons, stents, with blockages. And this is just a little bit different than that. So it's very easy to learn. So this can be more generalizable in the country. More hospitals can learn to do this. More people can learn to do this easily and produce good results as opposed to the surgery. So indications for ablation remain, first of all, that you need to have suitable anatomy. There has to be an artery that is supplying that bulged part of the septum. The artery has to be big enough for us to be able to go in and put a balloon and inject catheter. If you don't have that anatomy, then we can't do this procedure. And the second indication is that we do it only if medicines have failed. So if patients remain symptomatic or are not tolerating the medications well, then we go and do this procedure. If the patients are doing fine with medications, then there is no role of these procedures, then we treat them with medications. And finally, it's a patient preference too. There has to be a discussion between the treating cardiologist, which in our case is Dr. Tajik, and the patient and the team. Many times he will send the patients to meet with me, he will send the patients to meet with the heart surgeon, and then he will meet with the patients again, and then let the patient decide what they want, because there remains this debate who should have surgery and who should have the catheter-based procedures, and I will briefly go into that in a couple of minutes. But patient preference is very important. So right patient, right anatomy, and right indication, that patient who are symptomatic. So once we do this procedure, once we inject alcohol, what do we expect? We expect that the gradients, that pressure to drop. It takes 3 to 6 months for us to achieve that result. And you can see from this one paper that the pressure continues to slowly drop even further and remains low over the next 9-10 years in this paper. The ventricle, the septum thickness goes down after this procedure in 3 to 6 months, and slowly even more over the years as that part of the muscle becomes scar and thins out slowly over time. And MRI is very helpful in reviewing the results of our procedures over time. And then what do patients feel? patients start feeling better immediately after the procedure. Their symptoms of shortness of breath, their symptoms of chest tightness goes down, and their exercise tolerance goes up. You're less fatigued and you're able to do more without having symptoms. And that result then persists for a long duration of time. So it delivers good results, and the results are reliable for a long time. And also what we have seen by relieving the obstruction, it is very clear in the surgical data that when you relieve the obstruction, that you bring that patient's survival to somebody who does not have obstruction. And with ablation, we have seen, this is again Mayo Clinic data, but other centers have published similar data, that when you relieve the obstruction, you improve the survival of the patients, and they're similar to patients who are not obstructed. There's no head-to-head study between surgery and ablation. There are registry data where patients who have had surgery are compared to patients who have had this catheter ablation. And this is, again, from Mayo Clinic, showing that the results of ablation match that of surgery in most of the regards. So till very recently, we have kind of reserved this ablation as a second line to surgery. So if a 30-year-old patient goes to see Dr. Tajik and he tries medications and patient is still symptomatic, the next step would be to have him see an experienced surgeon and have myectomy done. If the patient is older, let's say they're 60 years old, they have bad lungs or other illnesses which make surgery a little more risky, he would typically refer that patient to us for catheter ablation. And that has been kind of in the guidelines too, and other centers have had a similar approach in the United States, at least, to reserve the ablation for older, sicker patients and reserve myectomy for the younger, healthier patients. This paper is from a couple years ago now. Very important paper, comes from the Scandinavian countries, where you can see they had 1,200 patients who underwent alcohol septal ablation, and they took all age groups, and you can see their ages of their patients ranged from 13 years to 88 years. A bulk of the patients, again, in that middle age, but a significant number of patients who are lesser than 50 years of age, who in United States we would have referred directly for myectomy if there was no other compelling reason for them not to have surgery, but they performed alcohol septal ablation on these patients. And interestingly, what they showed is, if we look at this group of patients, which is less than 50 years of age, their 1-year survival after procedure, 99%, 5-year survival, 95%, 10-year survival of 91%, as opposed to the older patients. So they showed that even in young patients, less than 50 years of age, the alcohol septal ablation offers excellent results with excellent long-term survival without any major complications. This has led to some change in our thinking too, again, with a very open discussion with the patient of what their preferences are and whether they would want surgery or whether they would want alcohol septal ablation. So there are pros and cons to each procedure, and as I said, septal ablation is more widely available. More centers can do this with good technical results. Surgery is highly technically specific to each institution. With the alcohol septal ablation, the hospital stay is shorter. We watch patients typically for 48 to 72 hours. We achieve success in over 80–90% of the patients. We can go and do this procedure a second time very easily, as opposed to sending a patient for a second surgery. And there's enough data now over the last 20+ years that this also offers long-term survival benefit and offers durable results in relieving patients' symptoms. The only con I would like to mention here is that there is a little bit higher risk of needing a pacemaker. And that varies from center to center. It has varied over the years. It varies. There's a paper that was just published yesterday that shows, which Dr. Tajik also kind of mentioned, that women fare worse than men in alcohol septal ablation. And in that paper from yesterday, 14% of women ended up needing a pacemaker, and only 4% of men ended up needing a pacemaker. And in our experience, we have also seen similar results that in general, about 10% of the patients will end up needing a pacemaker. So I'm going to quickly, do I have a few more minutes? I'm going to quickly share this case again. This comes from Dr. Tajik. This patient was diagnosed with hypertrophic cardiomyopathy in 2011 at Mayo Clinic. She is from Wisconsin. Around the same time, Dr. Tajik moved to Wisconsin, so she started seeing Dr. Tajik here. She continued to remain very symptomatic despite medical therapy. Has no family history of hypertrophic cardiomyopathy. So these are the medications that Dr. Tajik had her on. She was on a good dose of beta blocker. Her heart rate was slow, so she could not tolerate higher doses, could not tolerate adding a calcium channel blocker because of heart rate issues. She was on diisopyramide, a good dose, and other medications. And despite that, remained quite symptomatic. This is her echo with Dr. Tajik, and you can see the ventricle is very thick, but more so the basal part of the septum, and pulling that mitral valve towards the septum and creating even worse obstruction, as well as creating mitral regurgitation. So you can see in this, again, there's the blood flow here should be red and blue. It should be very laminar flow. When there is obstruction, it creates this yellow greenish color, which indicates that there is turbulence and that there is obstruction. And when Dr. Tajik puts a Doppler in this area, you can check the pressure by these Doppler signals, and that shows very high. A normal person would have somewhere in 1.5 type of a velocity here, and you can see this velocity here on the scale goes up to over 6 meters, which indicates very high pressure gradient, which they measured at 130 with the Doppler. The other thing that is worth mentioning here, and Dr. Tajik has written about this, is the respiratory variation in this pressure, whether even worse when patients are sleeping. So patients have sleep related breathing disorders, more so in hypertrophic cardiomyopathy, making this obstruction worse. And similarly, breathing affects this pressure gradient, which was described by Dr. Tajik in one of the papers he has written. So next step, obviously, in this patient was to proceed with something else. She's in her 60s, she's symptomatic despite medications. So the procedure is quite simple. And some of you may have had it. It's just like any other catheterization, which has become an outpatient procedure these days. We put a small catheter from the wrist. In this case, we have to put 2 catheters. So one goes from the wrist, one goes from the groin. These are small catheters the size of a drinking straw. We inject the dye, we take pictures, we find the septal, we measure the pressures. This red pressure is pressure in the aorta. The yellow pressure is the pressure inside the heart. Typically, both pressures should be equal. There should be no difference between those two pressures. You can see there's a huge difference here, just like the echo predicted. Inside the heart, the pressure is 200. Outside the heart in the aorta, the pressure is 100. And you can see with the respiration, this white line is indication of respiration, that the pressure changes. But in all phases of respiration, there is a difference between the red and the yellow. So the pressure inside the heart is very high. So we'll go in with a balloon inside that septal artery. We inject alcohol, which on echo then looks like very bright white signal here. And that's our target area. It helps us figure out if we're in the right area, injecting the right area. And we then go ahead and inject alcohol and see immediate results. You can see on the table that the yellow pressure has become equal to the red pressure. So you have eliminated the obstruction immediately on the table. and we assess with echo with this pressure. And once we are satisfied with the results, we stop. The patient is observed for a couple of days to make sure that they do or do not need a pacemaker. This patient's dose of medications was over time decreased. She did not need a pacemaker. This is from a couple years ago. I think she's probably at her 4-year follow-up now, but at 2-year follow-up by Dr. Tajik's note, he mentions she's walking 5 to 6 miles. She's bowling once a week, and she has no symptoms at all. This is her 2-year echo. You can see that basal part of the septum has become thin. The blood flow is much more laminar, and there is no obstruction. So this is really the main catheter-based procedure we have available at this time, the alcohol septal ablation. There are other procedures that have tried to do something similar without using alcohol. There are some centers that have used glue or coils. They pretty much do similar, provide similar results to alcohol. So there's nothing better than alcohol at this time to inject inside the septal artery. There are a couple other novel procedures which can be tried in patients where septal ablation may not be an option. One of them is this mitral valve plication. There's a procedure called mitral clip, which we do for procedures who have people who have a leaky mitral valve. And this group from Minnesota tried the similar concept that instead of making the septum thin, let's say there is no septal artery to inject there, what if we pull this mitral valve, which is getting pulled towards the septum and creating obstruction? What if we pull it back towards the other side and clip it to the other leaflet and not let it go into that outflow to create obstruction? So we do this procedure for not this condition, for other conditions. So they tried the clip for this procedure, and this is mitral clip. It's a very small clip. It goes through the vein in the groin inside the heart. We put the clip, and basically this is some of the preliminary data from such a procedure. 15 patients had this, showed significant reduction in a gradient, and all of the patients had significant improvement in their symptoms. So this again is not approved for this condition, but could be done off-label for this condition in patients where septal ablation may not be an option. And then finally, I want to share this one very interesting paper from China, where they have tried this new procedure of ablation of the muscle, not with alcohol, but with radio frequency, which the electrophysiologist, Dr. Saram, may talk about that. They do this all the time to burn inside the heart to get rid of arrhythmias. Here, these Chinese doctors burn the muscle to get rid of the thick muscle. And they do it very elegantly, going through the skin in the chest under echo guidance, put a needle through the tip of the heart inside the septum, and then burn it from inside with this needle. This system is only available in China. It's not available outside of China, but they have shown excellent results. This is their preliminary data showing significant reduction in the pressure gradients on these patients, significant reduction of the thickness. They have beautiful MRI data showing the thickness of the septum significantly getting thinner and thinner over the next 3 to 6 months, just like with alcohol septal ablation. So this is something to look out for. This may become available in other countries too, and could increase the number of patients we can treat without surgery. But as of now, alcohol septal ablation remains the main catheter-based procedure for relief of LV obstruction. And I'm going to stop here. Thank you.
Thank you. I have one follow-up call question before we bring in our previously missing faculty member who I see is with us now. So we'll pivot over there. Did you get the data that piece on the new Chinese technique, for lack of better terms? Was there any heart block associated with that ablation? It looks like a very wide area, and I would assume that they would probably damage either the right or left bundle.
Yeah, I have to. I don't remember that off the top of my head. I can. I have that paper. I can look at it. I can answer that maybe after Dr. Sra's talk.
Okay, if you take a look at it. We
Sure.
do one directed question to you. Simple question, Carol. Good question. If somebody's considering alcohol septal ablation, they would go in for a cardiac cath. If you found the proper anatomy at that time, you would proceed with the alcohol ablation rather than bringing them back in for a second catheter and doing the procedure at that time. Would that be correct?
Majority of the times, unless there's any surprise on a cardiac catheterization, sometimes in the older folks, we may find blockages also, and that may change the plan, and then we may have to stop and bring them back. But majority of the times, it would be a one-stop shop type of a deal.
Fantastic. Thank you very much. I answered your question live there, Carol, so we're not going to be doing that one later. And you got both of your questions answered in one. So thank you, Carol. Okay, so we have our one that was going to be first, then it was going to be second, then we have him now. So Dr. Tajik, do you want to introduce your colleague?
Well, colleague is Dr. Jesse Sra. Where is he? I can't see him on the screen.
Well, he's over sharing his slides.
Dr. Jesse Sra.
Can you see my slide?
Yes.
Dr. Jesse Sra is the head of cardiology department, Aurora, Advocate Aurora Center. He is a Top Gun electrophysiologist, and he's going to share with us his expertise very briefly in this arena of arrhythmias and their management in patients with hypertrophic cardiomyopathy. Jesse?
Thank you, Dmi. So, Dr. Tajik asked me to talk about our technique we are using for patients who have atrial fibrillation, very, very refractory, which is very troublesome and difficult to treat, which we call a hybrid approach. And one of the reasons we have been able to do that is because of the way our department runs, where the surgeons and the electrophysiologists and the cardiologists are really working together as one team. A lot of people, a lot of CEOs of many companies have told me that that's very unique to our department, that how many different subspecialties work together. And that's one of the things which is important, because Dr. Kress, who works with me on this technique, has been is one of the best cardiac electrophysiology surgeons I know of. He did the first epicardial ablation for atrial fibrillation almost 20 years ago, and has done more than 1,000 lead extractions. And we have been working on this project for almost 10 years now. So just briefly as a background, 65 and older, 5% of the population has atrial fibrillation, 10% over the age of 85. So it's a huge problem, irrespective of the way you look at it. There are multiple risk factors: hypertension, diabetes, heart disease, and the family history. And one of the things clearly what we see is when the left atrial is enlarged or thick, that they also are very, very high risk of atrial fibrillation, even if they don't have any of these risk factors. But most of them will have some of this problem associated with enlarged left atrium, as well as a thick left atrium. And those are the problem cases as to how you deal with them from the ablation standpoint. If you look at this picture, this is the back of the left atrium. These are the pulmonary veins. And so what we see, and this is based upon multiple studies and observations over many, many years, that the triggers most of the time are in the pulmonary veins. I don't want to go into too many details, but there are ganglion plexi which are outside the veins, but they're interconnected with neurons with the veins. And some of the theory is that those GPs, as we call them, cause triggering of the pulmonary veins, because the architecture of the pulmonary veins is such that it sort of resembles like our sinus node, and that's why there is automaticity there. And then as that PACs come premature atrial contractions come into the atrium, the architecture of the atrium is such that it can cause atrial fibrillation. And a lot of times if the atrium is dilated, there's scar there, it's much more easier. So almost all cases with atrial fibrillation will start with paroxysmal, and then over time they could get persistent, because there is a saying that atrial fibrillation begets atrial fibrillation, that because over time there's more scarring, there is more stretching of the atrium. So just very briefly, these are recordings from different pulmonary veins. This is the right pulmonary vein, this is the left pulmonary vein. And what you see here is that this is sinus beat. And then when you're recording from different pulmonary veins, just to make the case what I was showing before, you can see atrial fibrillation starts, but you see very, very ugly activity in this pulmonary vein compared to this one, which is much more organized. So we call it as the culprit vein. But at some other time, a different vein may be culprit rather than this. But so this is the type of activity which starts when you're monitoring them, and then the patient goes into atrial fibrillation. So why is that important? Because that led to the procedure where you isolate the pulmonary veins. And the idea is if you isolate the pulmonary veins, you should be able to take care of most of the patients with atrial fibrillation. So there are two ways of isolating the pulmonary veins. This is a CT scan showing different pulmonary veins. One is that you can do radio frequency current, where you deliver a sort of a radio frequency targeted heat, which can go farther down. We can't run this movie, but this is a thermal imaging of radio frequency current, which you'll see that the heat keeps going down and deeper. And then, but it's a point-by-point ablation, and it can cause trouble because you can have gaps, and which create even more trouble because you can have reentrant circuits, what we call flutters. And when that happens, that can be even more difficult to treat than atrial fibrillation itself is. But it's a good, the technology is pretty good of doing that. The other approach is that you can use a freezing technique where you can actually use a cryo balloon, which is one of the balloons created by Medtronic right now. And then you can go to each vein and isolate by freezing, by making temperatures go to either, for radio frequency, the temperature should go to like 50 degrees plus. For freezing, it should go to like at least -30 to -40. But the end result is the same, that you can isolate the veins, and that way you can treat atrial fibrillation. So when you look at the studies, this is where one of the problems is, that even in patients with paroxysmal atrial fibrillation, whether you use radio frequency current or cryoballoon freezing technique, the results are still about 65 to 70%. So when you're talking about a patient who has failed medication and is very symptomatic, and you can be successful 65 to 70% of the time, it's a good procedure because there's no other way that you can treat these patients. And many times, even if you have a recurrence with the medications which have failed before, you can use those medications with the ablation procedure and have a little bit better success. So when you look at the guidelines, this is a little bit older slide. In the past, the guidelines were, if you have a paroxysmal atrial fibrillation, if you fail antiarrhythmic drug, then it's class 1 guideline that you can go to catheter ablation technique. It's class 2A to go straight to catheter ablation because of the results I showed you. If you have persistent atrial fibrillation, which by definition is that you require cardioversion, or the atrial fibrillation continues for more than 7 days, technically more than 48 days, then you start medication. If that does not work out, then 2A is catheter ablation. Long-standing persistent is basically patients who are in atrial fibrillation for more than a year, definitely more than 6 months, but preferably more than a year. And this was like a class 2B indication at that particular time. This is a 3-year-old slide. And I'll show you why that is important right now. So this is an example of a patient, 67-year-old, symptomatic, failed cardioversion, failed multiple drugs. He has had 3 ablations in multiple institutions, and all his pulmonary veins were silent. So he continues to have a problem. So here is his EKG. You can see this is the QRS complexes, and in between you see some sort of like a little bit organized, but not totally organized activity in the atrium. So it's more like a flutter fibrillation going on. This is his recording from a catheter placed in the coronary sinus. So these are intracardiac recordings, and you can clearly see it's very disorganized, and it's clearly atrial fibrillation that he's still having. So we did this procedure, the hybrid ablation, where we went into the pericardial space and we did the ablation from outside. And that's where it becomes important that patients which are seen by Dr. Tajik and his group, they have thick muscle, tough to ablate, and obviously they're very, very symptomatic. They can't tolerate atrial fibrillation like many other patients may be able to tolerate, you know. And so this patient was, we could convert him with this epicardial technique. So this is the same thing, the EKG, and it converts to sinus rhythm. You can see the P wave and the QRS complex. So this is a voltage map. This red means there is no activity. Green means there is a lot of activity. It's an epicardial voltage map created by the mapping technology called the CARDO. And you can see there is a lot of activity in the epicardium. And then after the ablation, essentially there's no activity. And that actually, so he was having an epicardial circuit. There was nothing there in the endocardium to cause atrial fibrillation. So just by doing epicardial ablation, the patient terminated sinus rhythm. So you can do radiofrequency ablation, which you deliver heat, and you can do cryoablation, which may be okay in many patients, but some of these patients who have thick muscle, it's very difficult to get a transmural ablation done. And if you can't get a transmural, that's where some of the failures occur. So that's how we started working on this technology, that what you do is you access the pericardial space. This is the catheter. It's pointing away from the esophagus so you don't damage the esophagus, which is a deadly complication. And there's a saline irrigation going on, and you do so you're delivering the heat towards the left atrial epicardial area. So if you look at the anatomy, so you essentially, you're delivering these lesions around this area and isolating most of the atrial pulmonary veins, but you can't go to the front of the pulmonary veins. So you still have to do endocardial approach. This is the access point, which is very, very easy. Patients can go home within 48 hours. They will leave a small drainage tube there in the pericardial space for 24 hours, but that's taken out, and the day after that, they can go home. So it's used for patients who have persistent atrial fibrillation for long-standing, who have failed drugs, or somebody like the patients with hypertrophic cardiomyopathy or even hypertrophic obstructive cardiomyopathy, where we have seen a routine procedure, although you can do it, if they're paroxysmal, does not work out very well. So in addition to the epicardial ablation, there are two ways of doing the hybrid approach. One is the sequential approach, where the surgeon does their part first. They can ligate the left atrial appendage. So if a patient is early on, patient does not want to be on anticoagulation, that's the advantage. The disadvantage is you have to bring them back 6 weeks later and do the endocardial ablation. 70% of the procedures we are doing is a combined approach, where we can do endocardial and epicardial at the same time, because we have hybrid room in the EP lab, where the surgeon, the Dr. Kress, can do the epicardial part and we can do endocardial part at the same time. So endocardial part will involve making sure all the veins are isolated, making sure there are no electrical activity in the septum, which is disorganized, what we call fractionated electrograms in the posterior wall. Posterior wall and pulmonary veins embryologically are the same, structure. So look at the posterior wall and then connect some anatomical areas like the roof of the pulmonary veins and the mitral valve to the pulmonary veins. So it's a very extensive procedure. It can take 6 to 7 hours, but overall pretty good. So if you look at these patients, these were the results. This is persistent patients as well as long-standing persistent, which nobody would touch. And the results are pretty good. When you look at the persistent, almost 80% success rate. When you look at long-standing persistent, which wouldn't have any chance of success, had 60+% success rate. So when we presented this data, so this is the paroxysmal atrial fibrillation, about 70% success if you just isolate the veins. And this is the hybrid approach in persistent and long-standing persistent. It was a class 2B indication for ablation, but this data is as good as paroxysmal atrial fibrillation data. So when we presented this data, actually the Heart Rhythm Society then changed this guideline to class 2A indication if we are using this type of technique for patients with long-standing atrial fibrillation. So until and unless patient has had atrial fibrillation for 5-10 years, we don't even say no to those patients. We take them straight for hybrid ablation. Or patient who comes persistent, in our experience, we have seen that patients who have hypertrophic cardiomyopathy or they don't do very well with just a pulmonary vein isolation. And if they're persistent and very symptomatic, we don't even worry about doing just a PV isolation. We just take them for this procedure, which is much more successful in many of these patients. So that is the technique. We have done close to 300 plus patients now. The long-term success based on whether it's persistent or long-standing persistent is somewhere between 65 to 85%. And half of them, we can stop the medications, antiarrhythmic drugs. And many of them after 2 years or so, if they are young patients, we have been able to stop the anticoagulation therapy as well. So it requires a lot of collaboration, between the surgical colleagues and electrophysiology colleagues. It requires a lot of sophisticated mapping tools and a lot of other technology to bring together to take care of these patients. That's it. Thank you.
Jesse.
Yeah.
Lisa, are you there? Yeah.
I am here. Thank you. I was just getting a message that I had to take care of. So thank you for taking the time to come and join us. I know you've been very, very busy, and that was really interesting. I know that the patient population with HCM and AFib is a particularly troublesome one. And the data was a little unclear for a period of time as to how to best manage HCM AFib. And the work that you guys have done have really helped to clarify some of these very complicated areas. If anybody has any questions, they can post them now regarding this particular talk, because I think our chief of cardiology might have another meeting to get to tonight after this, so I don't want to take all of his time. So if there's any specific questions, you can post them now. Not seeing any yet, but we're making people type kind of fast, and we can address that. There is a comment in the chat. Let me check on that as well. If I could get to chat, there we go. We'll get to that question a little bit later. Okay. All right. So no questions there. I thank you for your.
I just want to bring one point. I want to mention that our complication rate. So in 21 years, we've been doing this procedure. We haven't had any death because of the procedure. So we've done thousands of them. The complication rate between the hybrid ablation, which is almost takes 2 times longer time to do it, but as you can see is pretty aggressive, procedure, is the same as non-hybrid ablation procedures. So other than 1 day extra in the hospital and some discomfort because of the pericardial tube, there's no long-standing difference in terms of complications, acute or long-standing, between the two groups, which is actually remarkable because it's a pretty aggressive procedure, and you're doing it in patients who are very, very symptomatic, but our complication rate is no different than complication when you're doing just this straightforward pulmonary vein isolation.
I need to think about that one a little bit as to how you could accomplish that so systematically, and that's a heck of a challenge. And this is a very symptomatic population, and the fact that they are doing so well is a great testament to the time that it takes to do this right. I know some other labs, maybe not at HCM centers, but some other labs try to go pretty quickly and they want to get you in and out of the lab fast and they don't want to use that much lab time. So being in there for a while sometimes gets a little tedious for them. We do have a question from Betty. She wants to know what the role of AV nodal ablation is, in your opinion, in HCM.
Well, the problem there obviously is, and I think that Dr. Tadi could answer that question, when they're in atrial fibrillation, whether you do AV node ablation or not, you're still not having AV synchrony there. So the AV node ablation is a very good procedure in patients who are very symptomatic, who are elderly, and everything else has failed, because you can control the ventricle rate in those patients, and they just have to be in anticoagulation. So I have a lot of patients who have had AV node ablation over years. I still see a patient where we did a DC AV node ablation 32 years ago when I was a fellow, and I still see him with a pacemaker. So it's and he's gone all over the world. So it's a very good procedure for those patients. But for these type of patients which we are talking today, I don't think that's a good procedure, because you still have atrial fibrillation going on. You're just pacing the ventricle, so you're not achieve the ideal endpoint in those patients.
So in those patients, the other possibility would be to pace over the AFib rather than ablate the AV node.
You can't pace over the atrial fib because the atrial rate is going at 600 to 1,000 times per minute. So there's no way you can pace over that fast.
I was waiting for that question to come up, so I asked it preemptively. Okay, I don't see any other questions coming in, and we are rounding the curve to our final speaker, who I do have to say was the first one to log on tonight. So he gets his punctuality award. Assad, you are up, and we are going to be talking about a matter near and dear to my heart. Look, I brought her up further so she could watch the talk closer. My heart is literally in the box. We might bring her out later. So let's talk about advanced heart failure.
I just want to say one thing. Can I say one thing, Jimmy, before?
Yes, you can. You're the
so
boss.
You may have mentioned that the weekend before last, our program did the 1,000 heart transplant. Kudos to the Department of Heart Failure and Advanced Transplant. And during the pandemic, they did twice as many heart transplants as the year before. The reason was that St. Luke's continued the heart transplant program, while many other programs in the Midwest shut down or were not doing it too much. And so these guys did a great job, did twice as many transplants during the last several months as year 2019. And they did the 1,000 transplant about 2 weekends ago. So
well, congratulations.
Yeah.
That is a massive accomplishment and puts you in a very small group of transplant programs in the country, if memory serves me correctly.
Yeah.
Yes.
Okay, let's hear from Dr. Asad Ghafoor. We've been
Can
waiting.
you hear me?
Yes.
You all hear me? Okay, good. So let me start off by saying that this last place presentation is very befitting, and you'll soon find out why. I was asked to primarily tell you about the role of advanced heart failure therapies in hypertrophic cardiomyopathy. And of course, I just quickly want to show you that I have no disclosures. The reason this last place presentation is befitting is because, like Harry Truman, advanced heart failure therapies, the buck stops with us, okay? Dr. Tajik and Dr. Galaska and Dr. Sra and Dr. Alakaban and their techniques and toys and all their published data. When those things don't work for you, that's when you come and see Dr. Ghafoor, okay? And a couple of things to mention here for us, a lot of times everybody wants a more patient-tailored approach, but for heart failure and transplant doctors, that is really the only thing we do, because if the guidelines or the recommendations from societies were to work for you, you wouldn't be seeing a transplant doctor. So we have to tailor your care specifically to you and to your disease and see what will work for you, because not everybody has the same wait time on the transplant list. So the buck truly does stop with us. Now, I want to tell you a little bit about Aurora St. Luke's transplant history. I'm not gonna bore you too much with scientific detail, There's a lot of non-medical personnel in this group. But I do want to emphasize the history we've had, and that's important because, as Dr. Straub pointed out, we recently did 1,000 transplants, and there's a very rich history here at Aurora St. Luke's for heart transplantation. So in October of 1968, which was 10 months after the first heart transplant in South Africa, we had the first heart transplant in Wisconsin at Aurora St. Luke's. And the most lasting thing about this transplant in particular was that this patient, among all the transplants that were done in the first few years, was the longest living patient. This patient died 8 years later in 1977, and actually in 1977. So it was like more than 8 years, 9 years. At that time, that was unheard of. Most patients who had heart transplantation were dying in weeks or maybe months. Most people were not even making it to their first transplant birthday. So this was a time when people didn't know about the importance of immunosuppression. And this particular patient most likely, for sure, definitely got lucky. The HLA matching and antibodies that we test for now, it was the luck of a draw for this patient that everything probably worked out. And even though we didn't know it at the time, without immunosuppression, this patient lived for almost 9 years. So we started heart transplant here very early. We were part of the pioneering experience. This is that first patient from West Allis who was transplanted in October 1968. She was discharged from the hospital 2 weeks later. And to the right, you can see her in a bowling alley in 1971. And as the picture says at the bottom, she died at the age of 57 in March of 1977. So this was unheard of. And that's why this made it to the New York Times. That first clipping I showed you was from the New York Times in 1977. This was big news that a heart transplant patient lived for almost 9 years. So, at Aurora St. Luke's, we have historically done around 25 to 30 heart transplants for a very long period of time. But this past year, as Dr. Straub pointed out, there's an asterisk next to 2020 because of COVID. When COVID happened, a lot of transplant centers did shut down because there was a level of uncertainty that was almost unprecedented. We weren't sure. Initially, if some of you remember, that even the test was not perfected yet. We didn't know who had COVID and who didn't. But for a lot of these reasons, transplant centers basically shut down. What that did for us was that it made the pool of organs available larger because there were more programs that were shutting down and fewer programs that could take or procure these organs. And I think that was a key ingredient to this past year for us because we continued through COVID and we ended up the year with 50 heart transplants, something we hadn't done in the last 10 years. And of course, also in the process, we surpassed the 1,000 heart transplant mark. So it's not only heart transplants that we've done 1,000 of, we're also getting close to 1,000 in the ventricular assist devices. And this combination of 1,000, both in heart transplants and ventricular assist devices, this is rare. In the Midwest, just to give you some comparison, other than Cleveland Clinic and University of Michigan, nobody else has done 1,000 heart transplants and close to 1,000 ventricular assist devices. And I'm including all the programs in Chicago, Mayo Clinic in Rochester. All these programs have not done this. So experience, definitely goes to our benefit. And when we look at our data, now I can't say this about all of the 1,000 patients, but the data that I could review, I can tell you that approximately 3% of our patients, transplant recipients, are hypertrophic cardiomyopathy patients. But of course, I think we are benefiting from Dr. Tajik's experience in this area. He runs a very specific hypertrophic cardiomyopathy clinic. And it is very likely that a lot of hypertrophic cardiomyopathy patients have been transplanted in the past, but they may not have been called hypertrophic cardiomyopathy because we didn't have Dr. Tajik maybe 20 years ago at Aurora. So the numbers for that reason are more reliable over the last 10 years since we've had a dedicated hypertrophic cardiomyopathy clinic. One thing in the transplant world that is very important to pay attention to is how well does a program do in terms of outcomes. And there is a website called srtr.org, and it's a website that is managed by UNIS, which is the organ sharing network. And they publish 1-year outcomes for every program. And this is not just for heart transplant, this is for other organ transplants too. And the benchmark is 90% survival at 1 year and generally around 75 to 80% survival at 5 years. And as you can see, this is, I copied and pasted this from srtr.org for our organization yesterday. This is our average over 2.5 years for a 1-year survival for transplant patients. This is from, I believe, sometime in 2017 till June of 2020. So we're above the expected benchmark. And of course, we're very proud of that. What are the indications for heart transplant? I think that's something that a lot of hypertrophic cardiomyopathy patients want to know. When should my doctor send me to a transplant specialist? And the simple answer here is when they cannot control your symptoms, despite the medications and the ablations, or the surgeries in some cases. And of course, you are limited because of your symptoms. You are always tired. You are always fatigued. That is the most common reason. But of course, this is a condition that can sometimes go straight, directly to sudden death. So ventricular arrhythmias or malignant ventricular arrhythmias, which is basically arrhythmias that happen in very quickly or are difficult to control, that even though you may not have had symptoms for a long period of time, itself could become a reason to refer you to heart transplantation directly. And in a lot of these cases, these are younger patients who've not really struggled through many years of heart failure, but they have very suddenly and very kind of forcefully been jolted into this life of hypertrophic cardiomyopathy. There are exceptions for patients with hypertrophic cardiomyopathy, and I'm not talking about exceptions for listing. What I'm saying is that when we generally evaluate people for transplant, we do tests that tell us when it is time. And there is a test called a cardiopulmonary exercise test where we measure oxygen. How much oxygen is the heart using? And that tells us how weak the heart may be. The less the oxygen the heart is using, the weaker the heart is. And that number for most patients is 14 if they are not on beta blockers. It's 12 if they are on beta blockers. If you're younger, less than 50 years old, then it has to be less than 50% of your predicted for your age and gender. But when it comes to hypertrophic cardiomyopathy, this doesn't apply. And sometimes that's because of arrhythmias. And sometimes it's because the patient is telling you, I am just, so fatigued and tired. Their oxygen number may be 16 or 18. It may not be below the traditional cutoff, but you don't want to not list this patient. You want to list this patient because a heart does not immediately become available. There are people who wait many months, sometimes years for a heart transplant. And you don't want to lose the hypertrophic cardiomyopathy patients on the wait list because you waited too long. So the moment you suspect that their symptoms are becoming refractory, harder to control with the medications and everything that you were doing so far, I think that is the moment to go ahead and list them because the heart will not become available right away. And waitlist mortality for other reasons also, but waitlist mortality is a problem for this group. And I'll elaborate on that in a little bit. Of course, as you know, ejection fraction in hypertrophic cardiomyopathy is not often low. It may be low in burnt out cases, but is often preserved. The good thing though is when these patients do get transplanted, as I will show you, they tend to do better than their other counterparts who don't have hypertrophic cardiomyopathy. And I'll show you some information on that. So as some of you probably know, in November, maybe, the American College of Cardiology, American Heart Association revamped their guidelines for patients with hypertrophic cardiomyopathy. The only thing I want to show you here is, the gist of it is, if you are having symptoms that are difficult to control, or you are having arrhythmias, as shown by, these two flow sheet areas, you are then eligible to be evaluated for transplant. That is kind of the gist of this. And this is something that I wanted, of course, most hypertrophic cardiomyopathy patients to understand. If you are having symptoms despite the best medical therapy and procedures, it is time for your doctor to refer you. Now, in end of 2018, the heart transplant listing categories were changed. And this is because the prior listing categories were too simple. And they were good for a lot of people, but they were not good for people who were in specific subgroups like hypertrophic cardiomyopathy, congenital heart disease, restrictive cardiomyopathy. All these patients, they lost out often in that very simplified algorithm. And so the Society of Heart Transplant basically decided we need a more elaborate system for listing. And now they've given hypertrophic cardiomyopathy a specific group, status 4. And so if you have hypertrophic cardiomyopathy, you don't have any contraindications to transplant, and you're going to be listed, you will go to status 4. You won't be at the bottom like status 6 or 7. You will go to status 4. And of course, if you're having more arrhythmias, you can be even made status 3 or 2 in some cases. But this was very, this made a big difference because before this, there was no protection for hypertrophic cardiomyopathy patients. When they needed to be listed, we basically had to prove with exceptions and narratives that they deserved a higher listing category. And this way, they're always going to be protected with at least status 4. This is just to show you with the new status listing, status 4, which is right here, is the bulk of transplant patients are status 4. This, of course, is also because there are a lot of LVAD patients waiting for transplant. They will also be in status 4. So if you were just curious, where does status 4 stand? Status 4 is right here. The top 3 categories is where you have the much higher likelihood of getting transplanted quickly. But of course, as you can see, all these categories in general are less than 15 to 20%. So earlier, I mentioned how hypertrophic cardiomyopathy patients tended to do well after transplant. This is data from 2018, and it's 16, 17 years of data. You can see the green line here is hypertrophic cardiomyopathy patients who got transplanted. Their 5-year survival is close to 85%, okay? And the other groups are non-hypertrophic cardiomyopathy patients who either had ischemic or non-ischemic cardiomyopathy, and their 5-year survival is somewhere in that 75 to 80% group. So we know for a fact that when hypertrophic cardiomyopathy patients do make it to a transplant, they do better. And a lot of times this is because they are younger. If we can somehow get them to transplant, we definitely help them benefit a lot more. Now, I want to caution you about left ventricular assist devices. I'm only showing you this because on an infrequent basis, hypertrophic cardiomyopathy patients can be considered for left ventricular assist devices, but the majority are often not eligible for left ventricular assist devices simply because the heart is so thick and the cavities are so small that there's no room for a device like this to work. But on rare occasions, and especially burnt out hypertrophic cardiomyopathy patients, and situations where a transplant is not going to be available quickly, and you're just trying to get them to a transplant, you may use something like a left ventricular assist device to get you there. This picture, shows you the actual pump as it is attached to the apex or the cone part of the heart. The batteries in close to the sides, and the drive line as it comes out the front of the abdominal area, and the controller usually sitting in a fanny pack, and the drive line is attached to that. I've deliberately put in the website here, patientdecisionaid.org. This is a very good website to educate yourself about LVADs if that is what your doctor is saying you should consider. The other thing to remember about LVADs is that, of course, there is some nomenclature involved, and bridge to transplant simply means you will be listed for heart transplant, and this is just a way to get you there. Destination therapy will mean that you're not a transplant candidate most often. And there's some interchanging here. Some patients who are destination therapy become bridge to transplant, some bridge to transplant become destination therapy. But remember this website, patientdecisionaid.org. And I can give you more information on left ventricular assist devices, but I'm not going to spend a lot of time on this because for a majority of hypertrophic cardiomyopathy patients, this is not a solution. So it's hard not to talk about COVID after 2020. So in our program, starting March 15, of course, as you know, we did continue to transplant for all ages. We didn't discriminate. We didn't say, oh, you're over 65, so you're at high risk for COVID, so we won't transplant you. No, we kept transplanting. We, of course, imposed quarantine policies, all these meetings and even educational conferences, everything became Zoom. Patient visits became virtual whenever it was possible. It became a priority to do virtual visits. And it's very disheartening for a lot of patients, but there was no way around this. There was a no visitor, very strict no visitor policy imposed. And the only exception that I saw made were actively dying patients. I know some other programs were making exceptions if the patient was going for a big surgery, the day of the surgery, things like that. We didn't even have that. We took more precautions. It was only actively dying patients that had visitors allowed to them. So that part was very hard on the patients and even for us to watch. But those were the times we were living in, and we still are. Hopefully not for too much longer with the vaccinations becoming available. I am proud to tell you, though, that in 2020, despite COVID, we had no COVID deaths in our heart transplant patients. We had heart transplant patients that did get infected. Of course, that was only a matter of time, but nobody died. And we had no COVID deaths in our LVAD patients who were done in 2020. However, there were COVID deaths in LVAD patients. They were not eligible for transplant. They had other comorbidities, but nobody who was either eligible for transplant or received an LVAD in 2020, died because of COVID. So we are very proud of that fact. Future direction, as Dr. Tajik initially pointed out, and this is still not FDA approved. Mavacamten, of course, with this Explorer HCM trial, that was published, I think 6 months ago. This is very promising. And basically the drug is, it works by keeping your heart from beating stronger. And so it's what we call an ATPase antagonist. And there's a lot of promise here. Everybody's hoping this will be approved by the FDA. The trial showed that it basically had a strong signal in all these areas. The gradient with at rest or with Valsalva improved. The ejection fraction, of course, did not drop too much, and that's good to know. But also post-exercise LVOT gradients improved. There were a lot of other markers. The trial primarily was looking at what we call NYHA class status to see if you were, having less symptoms or no symptoms. and a lot of the patients who were on the drug versus placebo had, less symptoms. So overall, they were not looking at hard outcomes like living longer, but it was a success in a lot of our minds. And this is the first time that a drug, has made it this far. So far, it was only surgeries or invasive procedures for hypertrophic cardiomyopathy patients or transplant that could prolong life. So that is my presentation, and I'm happy to take questions. But thank you for the opportunity, for the privilege. And as everybody has said so far, Dr. Tajik has made all this possible. We're very grateful for his presence and wisdom. Yeah, every now and then, of course, we do like to tease him. Thank you.
Dr. Gafu is a good friend.
He's a bit teasable. So I wanted to bring out some special guest stars after this call because I have two very good examples of HCM transplant hearts. Half of my heart is in my hand right now. So if you don't want to see it, look away. This would not be a good time. So that is what was functioning my body. You'll see there's not a big cavity there. So, that would have been better. So that's my old girl. And in just a few short weeks, she'll have been out of my body for 4 years on February 2nd. But you can see when you get really close there, the scarring is pretty evident. The papillary muscle's completely scarred in. And that's a very teensy tiny ventricle, not good for an LVAD. However, Hannah also donated her heart to the HCMA. And Hannah had a very different presentation. At the end of her heart, after she was listed, she bubbled out her ventricle and looked like that. And she was about to go for an LVAD. Her ejection fraction got down to about 20%, and they finally found her a heart. She took about a year plus on the list. She was an O, so that was challenging. I was an A+ blood type, and I was 6 months waiting for mine. So you don't know how long it's going to take. So if you think you're going down the transplant path, we can go a little further. And she can nod her head yes or no if I can bring up another one. Okay. So Amy, who is our meeting coordinator for the HCMA, is also a heart transplant. And as convenience has it, I have Amy's heart in my hand right here too. And that is, again, a bit more like mine. I think our hearts look like each other because I'm kind of short and squat and she's tall and thin. So our hearts look like us. And you can see all the scarring there. And that's a really small ventricle yet again. So probably not a great LVAD. Would you agree?
Yes.
Okay. So there's other transplant patients that were logged in tonight. So I don't have their hearts here with me tonight. I do not believe. But these very precious gifts are wonderful education tools. And we thank those who have let us use their hearts for education on behalf of those with HCM. So thank you for that. And now I have hearts sitting all over my desk. It's always quite weird to do that. Okay, we're going to go back to some Q&A. If anybody has any final questions, now would be the time to post them in the Q&A box, and we can address those.
While we are waiting for the Q&A,
Yes.
I just want to recognize two of my nurse practitioners par excellence.
Yes, ladies, there they are. We have Heather and
Michelle Bush.
And Michelle, and then we have Julie and Amy back on the screen with us.
Great. Okay.
So we can address any questions.
Oh.
I will give a few more moments to live stream through Facebook, and then we're going to take it off of Facebook so that we can address questions a little bit more personally. When we take it off Facebook, we end the recording. So any questions you ask after we stop the live stream will not be included when this presentation gets uploaded to YouTube and is kept forever and ever in the archives of the HCMA. So if you don't want to ask your question publicly, you'll have a few moments to do so privately. So let's go back to our friend Jimmy from earlier, who was trying to figure out, why is he getting worse? He had his myectomy 6 years ago. What's happening that he's not feeling so good now? And how would you tease out why somebody's having a change in symptoms when they're no longer obstructed?
Who are you asking that question?
I'm going to ask you because you're the big cheese here.
Oh, yes. So I think we have to remember that whatever is done is only limited procedure that's performed. Hypertrophic cardiomyopathy involves pretty much the whole left ventricle. So if the obstruction is gone, the stiffness of the muscle, excuse me, may have improved initially, but eventually the muscle stiffness catches on, and unless some preemptive medications were used over long term, that is what most individuals suffer from. And consequences of that are high pressures in the lungs, shortness of breath, tiredness, decreased output, and so forth and so on. So unfortunately, individuals feel that after cardiac surgery, they don't need medications. After Alko septal ablation, obstruction is gone, we are cured. So it's not a cure, it's just one particular issue has been tackled, but not the entire hypertrophic disease is still there.
So the answer is, I just had to put those things back in a bag and I didn't want to make all that noise.
And I see Matt Umland has shown up. He's been, without his help, I think at least I would have been kaput, but he is a great help in many aspects.
I think this is the definition of it takes a team or it takes a village to make all this work. And Matt's been helping with some of the AV and technical aspects. So if everybody thinks these meetings just kind of miraculously appear and everybody just knows when to show up and how to log in and do everything, there's a little bit more to the back end of making this actually work. So thank everybody who participated, and you have a wonderful team there. Are there any other questions from the audience that want to do them in writing? We will do hand raised questions and unmute your mic to ask a question in just a few moments if you want to wait. So what I'm going to do at this time is I am going to stop our Facebook stream. So thank you to the viewers on Facebook, and next time, hopefully you'll join us in the Zoom room. Goodbye, Facebook. And now I am going to stop recording. You should all hear a little thing that says